Okay,
Thank you.
thanks, Julie, and welcome all of you. I guess there are a few people out there. It's a bit different, sort of looking at it through a Zoom lens rather than sitting in the seminar room. Anyhow, I've been working on a human genetic disorder, ataxia-telangiectasia, for a number of years. And what I want to do today is spell out for you some of the approaches we've been taking in going to a clinical trial for AT. This is a disorder that has no cure. There are a few clinical trials out there, and they've been partially successful. So what we wanted to do was to look at some of the background research we've been doing and try and apply that in a clinical trial. As you'll see as we go along, we've been fairly successful with that. And we're now going to go ahead and do a clinical trial under the leadership of David Coleman, who's at the Wesley and who's worked on the AT clinic for a number of years. And the part of the basis for that is the work I'm going to describe. But first, I want to just tell you a little bit about the syndrome. So ataxia-telangiectasia, as the name suggests, the first part relates to a movement disorder. And as you can see on the screen, here, the oops, I should be able to do it here. The second characteristic is ocular telangiectasia, and these are dilations of blood vessels in the eyes, and it's not clear why they arise. The most debilitating aspect of the disorder is progressive neurodegeneration. This affects the cerebellum here and largely Purkinje cells. It's a primary immunodeficiency disease, and it affects both T cells and B cell function. And more recent data showed that the innate immune response is also defective in patients with AT. As a consequence of the immunodeficiency, one sees a number of recurrent infections, and there are other complications that arise in the lungs as well, including bronchiectasis, which is the enlargement of some of the airway tissue. And eventually, pulmonary disease can arise as well, where you get fibrotic lungs. And approximately 40% of patients die for complications associated with lung disease. Other abnormalities include liver function defects, diabetes, and there's a heightened susceptibility to cancer in patients with AT. These are largely cancers of the blood. Another characteristic of AT patients is radiosensitivity, and of course, this complicates life for patients in that when they develop cancer, it's not readily possible to use radiosensitivity or radiation therapy or radiomimetic chemicals, since they are very debilitating in their effects on patients. So one has to sort of tone down the level of those. So the basis for the trial then is we're looking at the correction of mitochondrial function, of a mitochondrial defect in patients with AT, using replenishment of TCA cycle or Krebs cycle intermediates. And the work we've been doing in the laboratory for some time is based on the hypothesis that ATM, which is actually the protein that's defective in AT, it plays a key role not only in the DNA damage response, but also mediate in the plasmic reticulum, mitochondrial interaction, to maintain mitochondrial and more general cellular function. So why are we focusing on mitochondria? Well, there's quite a lot of data that has accumulated in the last several years, which point to defects in mitochondrial function and mitophagy. That's the turnover of mitochondria in AT. Now, I've listed some of these here, and these include evidence for intrinsic mitochondrial dysfunction. That is, mitochondrial membrane potential is abnormal. Second point is there's a new role for ATM in regulating mitochondrial function and mitophagy. And this has been largely done with ATM deficient mice. Loss of ATM induces mitochondrial dysfunction and compromised mitophagy in another study due to NAD insufficiency, and there's a role for ATM in mitochondrial redox sensing. In essence, what you see there is that ATM is located to mitochondria, and it's, located, sorry, the phone was ringing. Role in ATM mitochondrial redox sensing. It senses reactive oxygen species in mitochondria and becomes activated to protect the cell. So ATM is activated as well by ATP depletion and regulates mitochondrial function through a transcription factor, NRF1. So all of this data points to accumulation of abnormal mitochondria in AT, which would impact adversely on the function of the normal mitochondria. So what we wanted to do was to look at the possibility that ER mitochondrial contacts were important. And what I'm showing you here is interaction between the endoplasmic reticulum and the mitochondrion. And this is through a region, a specialized region called the mitochondrial associated membrane. And this is just looking at an enlargement of that here. So we're looking at the endoplasmic reticulum and mitochondria. And the important proteins here that are enriched in this MAM are the inositol trisphosphate receptor type 1, the voltage-dependent activation anion channel on the mitochondrion, and a protein called GRP75, which is localized on the mitochondria as well. But when the channel is activated, enhances the transfer of calcium between the endoplasmic reticulum and the mitochondria. So the essence of my talk then is really looking for abnormalities in this process, which might account for mitochondrial dysfunction. The system we used was human bronchial epithelial cells, and we're looking at their response in after glucose deprivation. So when you deprive cells of glucose or inhibit them with 2-deoxyglucose, you activate a stress response. So we're using HBEC, human bronchial epithelial cell, as a control, and B3, which is the ATM knockout. So we used a CRISPR-Cas9 here approach to knock out ATM. We demonstrated that by a number of assays, and I'm not going to go into that, but these are the two cell lines that we're primarily using in the system after glucose deprivation. So this first slide here shows that ATM is present in the nucleus largely in HBEC cells, and you can see in B3, it's clearly absent because we've knocked it out. And when we expose these cells to oxidative or to glucose deprivation here, what we find now is that we get activation of ATM, which is, activation of ATM, which is, activation of ATM, which is shown by ATM phosphoserine in 1981. So under conditions of glucose deprivation, ATM gets activated. So if there's no ATM, what are the consequences of that? Well, if we look at the next slide here, what it shows is that there's decreased survival of ATM in ATM deficient cells when you expose them to deoxyglucose. And that's sort of, I'm not getting control of this. So the upper line here is B3, which are the AT deficient cells. And you can see that when you expose them to deoxyglucose, there's a high level of cell death occurring. On the other hand, if you look at HBEC, which are the blue cells, blue here, when they're exposed to deoxyglucose, and green, what you find is that there's that amount of cell killing. So there's a big, big difference in cell survival. So not having ATM around predisposes these cells very much to sensitivity to deoxyglucose. So what we wanted to do then was to look in a bit more detail at that ER mitochondrial interaction, which I mentioned through the MAM, which is shown here, and just going back to demonstrate again, is that the IP3 receptor gets stimulated in this particular case by deoxyglucose stress, and the channel becomes activated. GRP75 now binds to IP3R1, and you get calcium transfer across. So what I'm going to be talking about is that interaction and calcium coming across and showing that it's deficient in that T cells. So what this slide shows is a proximity ligation assay. So we're looking at the association of GRP75 and IP3R1. If you remember back on the slide, we're looking at this association. GRP75 is on the mitochondria, but it's now coming into close proximity with IP3R1. And this is indicated here by a number of foci that you see. So we're looking at the untreated here, which are much the same for HPEC and B3. But when you expose them to deoxyglucose, you see an increased enhancement of association between GRP75 and IP3R1. And that's showing quantitatively here. So this is the untreated, and you can see that after treatment of the control, there's a big increase, and it's very much significantly different from the response that you see in AT. We then went on to look at calcium flux in ATM deficient cells, because our supposition would be that if that channel isn't forming properly, if the bridge isn't occurring, then there should be a deficiency in calcium flux. And we're using FURI2 here, labeled in the beginning, to look at release of calcium from the endoplasmic reticulum to the mitochondria. And you can see here in controls, in HPEC cells treated with 2DG, there's a big increase in calcium release. And on the other hand, if you look at B3 treated with 2DG, this is very much sort of reduced. The response is very much reduced. That's reflected as well if you move to calcium uptake into the mitochondria. So it's released here and been taken up here, measured by rhodamine 2. You can see again a very nice uptake response in the case of HPEC with 2DG, and B3 again a very much muted response compared to the control. So just to summarize this part of my talk then, we have a defect in IP3R1 B71 assembly and signaling in glucose-deprived ATM deficient cells. We've done a number of other experiments to show that as well, which I'm not going to discuss today in the interest of time. There's reduced ER mitochondrial contacts after stress. This is done in collaboration with Rob Parton, looking at electron microscopy, and reduced calcium release and uptake, as I just showed you, and enhanced sensitivity of ATM deficient cells to stress-induced cell killing. And all of this is linked to an ER mitochondrial signaling defect. What I didn't show here as well is that under these conditions as well, you see mitochondrial dysfunction in AT cells. So then the question was whether we might be able to correct the ER mitochondrial signaling defect as a potential treatment for patients with AT. And the approach we used was based on a compound called triheptanoin. Now this, I'm going to call it a C7, and it's been known as a C7 oil. It's a triglyceride composed of 3 7-carbon chain fatty acids, and each of these then clearly are heptanoid. So triheptanoin gets metabolized to heptanoid. It's a food supplement, so clearly it can be used widely. It's been used experimentally to treat metabolic disorders such as epilepsy, Alzheimer's disease, and Huntington's disease in the past with some sort of benefit. It's well tolerated. You can take 25 to 30% of daily caloric intake, can be represented by this compound triheptanoin, and it's antiplurotic. And by that I mean it replenishes substrates in the TCA cycle. So if you look to the right here, in this scheme, triheptanoin then gets metabolized to heptanoate, and that in turn gets metabolized to acetyl-CoA and also to propionyl-CoA. And both of those are able to enter the TCA cycle to generate NADH and in turn ATP. So that's the basis for how this works. For the work I'm going to describe here, it's with cells in culture. So it'll be the heptanoid rather than triheptanoid that we use. But we clearly will be using triheptanoid in patients. So this is just another schematic just to show you how the antiplurotic agents work. The C7 then generates acetyl-CoA, which enters the cells into the TCA cycle as citrate, going on to produce isocitrate and so on. But also C7 here produces propionyl-CoA, which enters the cycle as succinyl-CoA. So these together, these two entry points together, are able to drive the TCA cycle, produce more energy, and so on. So if we look at survival, then if you remember, what I showed was that the B3 cells were extremely sensitive to deoxyglucose treatment. If you add back C7, which is this one here, if we look at B3, where we've exposed them to 2-deoxyglucose, C7, now you bring survival back to levels that are approximately the same as control. So this is quite a dramatic effect on cell survival. If we expose AT cells to deoxyglucose, cut off glycolysis, then they're not able to rely on mitochondria as well as control. But if you replenish the mitochondrial intermediates with C7, as I've shown you here, you actually then improve the survival of these cells, which is sort of a very good start in sort of looking at the capacity of C7 to improve things for AT cells. This is just another example of that. What we've done here is to look at primary patient airway epithelial cells. Remember, we're looking at cell lines up to this, but these are primary airway epithelial cells, and we've clearly demonstrated the same thing again. This is just looking at AT. You can see they're very sensitive to deoxyglucose, and if you add back in C7, the red one here, you bring it back down. So this applies not only to cell lines, but also as well to airway epithelial cells in patients. And these are the cells we will be monitoring throughout the trial. If you look at that bridge formation, which I talked about between GRP75 and IP3R1, if you remember before, in the HPEC, we got a nice response up to 2DG, but a very much reduced response in the case of AT cells. But now when we add C7, you can see that it's very comparable to that. So we're forming that bridge as well. When we add C7, we energize the mitochondria and we get better interaction between the ER and the mitochondria. And that's evident here. If you look at before I showed you the B3 response with 2DG, but now when you add C7, it's very much the same as control. We look at the calcium flux in the ATM deficient cells. Remember before there was a reduced response with in the B3, and this is indicated by this arrow here. But when we add C7 now, we've increased that response, that calcium release from the endoplasmic reticulum into the cytoplasm up to levels that are equivalent to control. Same thing here occurs with uptake in the mitochondria. Again, remember it was reduced. Now, again, we've enhanced the amount of uptake into mitochondria with the C7. So just to sort of summarize that then, C7 is an antiplurotic agent which enhances not only intermediates in the TCA cycle, but also the uptake of calcium. So I showed you before, C7 produces acetyl-CoA, succinyl-CoA, and they drive the TCA cycle. But in addition to that, when the TCA cycle is working well, we're now forming better links with the endoplasmic reticulum, and calcium is able to activate a number of different enzymes like pyruvate dehydrogenase, isocitrate dehydrogenase, alpha-ketoglutarate dehydrogenase. So you're getting calcium, you're getting the added bonus of calcium being sort of sucked in, if you like, when the mitochondria are working well. And that's a very important observation. So then just to summarize my talk on this, heptanoid or triheptanone. But remember, we used heptanoate in cell lines. You would use triheptanone in animal studies and with humans. Enhances bridge formation and assembly and signaling in ATM deficient cells after nutrient stress. It increases the number of ER mitochondrial contact sites. As a consequence, it increases the calcium release and uptake. It reduces sensitivity to stress-induced killing. There was a dramatic effect there. And then, as a consequence, we suggest that triheptanone has potential as a therapeutic for patients with AT. So just then to acknowledge the various people, the person who did all of the work, the bulk of the work with this was Dr. Avery Yeo, and she's shown here on the right, with the patient, Aaron Jordan. Unfortunately, Aaron died recently. The head of the clinical team is Dr. David Coleman here, and Dr. Kate Sinclair also runs the clinic with David. And David's going to be setting up the clinical trial in collaboration with a number of people, including Professor Peter Sly, Dr. Claire Wainwright, and of course, Kate. And just looking at other members of the team, Zoe Dangju, here made the B3 cells. Mike Geddes has done a lot of the Western blots, which I didn't actually show you here. And Dr. Chong is doing some work as well with Avery. We've collaborated with Professor Rob Parton on the electron microscopy work, which I didn't show you. And as I pointed out, Dave's heading up the team to do the clinical trial. We've had funding from Brashat Foundation, which is an AT foundation set up in Queensland that works with patients throughout Australia. And the Children's Hospital Foundation is also providing funding to Avery. We're getting funds from the Wesleyan Medical Research. And as I pointed out in the beginning, the Medical Research Futures Fund will be supporting the trial that we expect to undertake from March next year. Thank you.
Thank you, Martin. I think David was here, but I think he's popped out again. David's not here. No. Okay. Does anyone have any questions for Martin from that lovely talk? If you can either put a question up in the group chat or unmute yourself. Firstly, Martin, how prevalent is AT? I may have missed this in your
over the years, there have been different sort of estimates, but it's probably about 3 per million. So we have about 50 patients in Australia.
Right, wow. So how many clinics are there? Because there's one, you were saying at the Wesley, your collaborator. I guess there wouldn't be too many around Australia, would there?
No, there's not too many, just one, actually. The clinic was established here in 2007 by Kate Sinclair. It was actually held in this building on level 3 for a number of years, but it's now held at the Children's Hospital Foundation and the Wesley. Sorry, not the foundation, the Children's Hospital and the Wesley. And there are a number of other clinics throughout the world as well, but not many, as I say.